really going to focus on hip and knee osteoarthritis. So really, what is osteoarthritis? So again, osteoarthritis is a disease of the joint, and it affects the entire joint, as well as all of the structures around the joint. So in this schematic, if you look at the screen, you can see on the left, we have sort of a normal joint where we have a sort of a nice bone. You have this sort of thin blue line that is sort of a schematic of our articular capsule. And inside that sort of light blue is our synovial fluid. The synovial fluid has one job. It basically makes nutrition and for the cartilage. The cartilage is sort of this where these little tabs are here. And the cartilage is basically the shock absorber on the ends of the hard bones. Its job is to act as a shock absorber. Also, it reduces the friction when two bones are sliding on top of each other. When we have osteoarthritis, what happens is the cartilage starts to degrade or break down. It starts to thin. And sometimes it even disappears. And when that happens, more things can become affected. So when the cartilage thins, the bone underneath can get hardened. There can be made cysts. If there's a meniscus in there, which is a thickened piece of the cartilage, it can get a degenerative tear. And the synovial fluid changes in its quality. So instead of being like a WD-40 type of material, the synovial fluid really becomes more like honey or ketchup, where if it sits there too long, it stiffens up and becomes more resistant to movement. And so those types of things are what's happening in sort of the molecular level of the bone. So when we have this osteoarthritis disease process starting around the joint, the cartilage degradation or the breakdown of the cartilage happens faster than the regeneration or the building back up of the cartilage cells. Normally, as we age, we have this kind of nice balance of cells getting broken down and then cells turning over and getting built back up. But in osteoarthritis, there's more basically breakdown than there can be built up. Okay, and that causes that thinning, and that causes the bone to get hard, possibly cysts to form, and all of these changes. So again, this is just sort of another schematic. We in a normal sort of healthy joint, we have this nice balance of regenerating and degenerating cells, and that's always happening even as you age. And then, but in a diseased joint, it gets more of an imbalance. And so, again, if we just sort of think about how the joint works, so cartilage, unfortunately, doesn't have very good blood supply, and it doesn't have any nerve supply. So how it happens is basically that the cells of your cartilage are like little sponges. And when you put load through those sponges, the cartilage gets its circulation and its nutrition through that synovial fluid. And that's a really important point, because when we have times where we don't put pressure on our joint, whether we have an injury, we spend 2 weeks in bed sick with a flu, we go into outer space, that pressure isn't putting any pressure on our cartilage. And so we don't get that nice balance of regeneration and degeneration of the cells. It actually increases how much we are degenerating the cartilage cells. So we need a sort of an appropriate amount of pressure to push down into our cartilage cells so that the synovial fluid can give it its nutrition and get it to be healthy. So it acts like a pump or a little sponge, okay? And this is the action that we need to really help it with its nutrition, okay? Now, you can see from this X-ray that, interestingly enough, some people who have osteoarthritis, it will simply affect the cartilage, okay? So we don't see any changes on an X-ray. And those people can have a significant amount of pain. So they may start to have a little bit of pain when they're walking or those types of things. They go to the GP says, let's take an X-ray. And they say, oh, it looks really good. I don't see any osteoarthritis. But what we know is that changes in the cartilage actually can't really be well visualized in an X-ray. And so those people may be, experiencing early osteoarthritis and have significant pain, significant loss of function, but there's no evidence of that on X-ray. Whereas with this X-ray that you're looking at, you can see the inside of this poor person's joint is really just tight. There's not a lot of space in there, not much space for the cartilage. And sometimes physicians will use the words bone on bone, which is like a, pretty terrible thing to hear, because you think, oh, there's no way that I'm going to be able to move ever again. But the big take home point is that actually in this person doesn't have any pain. So again, the cartilage doesn't have good nerve supply. So when we're having thinning of the cartilage, you might not actually be aware of that at all, at that point. But when you start to have severe joint damage, your symptoms may become more pronounced or more constant. But there really isn't a good link between pain and joint damage, okay? But again, like I said, joint osteoarthritis is not limited just to the joint. It really is affecting the whole joint itself, the synovial fluid, the articular capsule, but it also affects the muscles that are around that joint. So the muscles change as a result of the changes to that cartilage, as a result to decreasing that load that we're putting through the joint. And we start to make kind of some interesting compensations, like when we're getting up from a chair, when we're going up and down the stairs, when we're standing, when we're walking in the rough on the golf course, those types of things we start to make compensatory functional movements for. And then what happens is the muscles start to really become weaker, as well as the timing of how well they fire starts to be a little bit less precise. And we start to develop these malalignment and less movement patterns. So how do we know when you have osteoarthritis? And so this might feel like a little bit of a laundry list of what you deal with every day. And that's okay. If you might check the box every time I kind of say one of these. But basically, we should know that different people have different symptoms, and that osteoarthritis is a very variable disease. So some people may have this and other people don't. But one thing that we start to see in early osteoarthritis, now this might be, think back to in your late 40s, early 50s, that time, when you started to feel decreased stability in the joint. So that might have felt like things might be saying, oh, I really don't trust my knee anymore. I really just can't go down the stairs. I don't really want to do that. Or I always grab the handrail, that type of thing. People complain of sort of mild pain, maybe some intermittent swelling even. So some swelling around that joint. And then they might even say that they get a bit stiff, especially sort of at the end of the range. So when you're sort of at the biggest bend. So if you notice I can't quite squat, or like when I'm lining up a putt and I wanted to bend down into a squat, I don't do that anymore. Or it might be that I can't fully straighten my knee. It looks a little bit crooked or a little bit bent. Sometimes people say, oh, I'm starting to have a little bit of a limp, especially at the end of the day, or if I get tired, or like by the back nine, I'm starting to really limp. And some people notice noises, cracking, grinding, clicking. But typically in early osteoarthritis, this happens kind of intermittently. So it'll come and go. And it can happen as a result of a trauma. So something that has suddenly happened. So some people will describe they were walking and then they suddenly had to pivot on some ice, or it can happen sort of slowly as a result of no difference in changes, right? And so we know that from the research that typically these symptoms will actually start quite early on in osteoarthritis. So it'll start in your 40s and 30s, even into the late 30s. 50s, people start sort of selectively not participating in as many sports, not doing as much fitness, and then these progress. And the way they progress is sort of on this second box on the right-hand side, where we're really sort of not having much confidence in the joint. We're having a lot of more pain. It's becoming more intense. We may be taking medications more constantly. You're having that pain at night, or when you roll over, you're waking you up. You may be having a lot of stiffness, even, just regular bending and stretching. We start to see these more long-term joint alignment changes. So somebody might say, oh, that one knee is really bow-legged or knock-kneed, and people start to really not be able to participate in the sports or the activities that they liked before. And some people will say that, the joint is giving way, or they're really noticing a limp. So this is from the GLAD course. And some people will say, I just don't trust my knee. I have to be careful when I go up or down stairs. It feels stiff or hurts when I get up after I've been sitting watching a show for a while. When I get up, it starts to, really be sore. It aches in the morning. It aches at night when I've been on my feet. I remember when I had a sports injury back in my 40s, and now I'm really aware of that joint and, that type of stuff. Or, if I have my grandkids for the weekend, I'm just really paying for it and I'm really sore for the beginning of the next week, that kind of stuff. So what causes osteoarthritis? Well, there's a number of different things, but some of the things that put us more at risk, we put them into two sort of categories: the non-modifiable, or things that we can't really change, and then modifiable risk factors. So the rate of osteoarthritis will increase with age. Although we know that people in their 30s and 40s certainly do have osteoarthritis, we start to see more of a sharp increase after age 50. Now, a lot of people think this is sort of an inevitable consequence of aging. But that's actually not true, because some of the sharpest increases in osteoarthritis is in hand osteoarthritis. And so we know that as people age, it's that they are, the changes in the joints are actually happening to their entire body, not just the weight-bearing joints in their legs. Women are more likely to develop osteoarthritis, especially after the age of 50. And then we know that there's a complex set of hereditary factors, so genetic factors. So if your parents had osteoarthritis, you might be more likely to develop osteoarthritis, although it's not sort of a direct link, there's just more of a likelihood. And then we're going to discuss this modifiable risk factors, or things that you actually have some control over. So weight, and certainly I am giving you this information, but with full understanding that we are in a pandemic, and that if you've gained a little bit of weight during the pandemic, you are in good company with me, because I have too. I know it's hard, but I will just describe this in terms of osteoarthritis. So how does osteoarthritis really get affected by weight? Well, one is that mechanically it does increase the load that we're putting through each of your joints. And so we know that if your BMI is greater than 25, you're going to have higher risk of developing knee osteoarthritis. We also know that if you have a moderate weight loss, that people with osteoarthritis will decrease their amount of pain just through that weight loss. So, and it can be a very small amount of weight loss. So if we think that the joint reaction forces, going through the hip or the knee is about 2 to 3 times that. So if we lose, 5 pounds, that means that off of your hip and knee, you've lost, 10 or 15 pounds of that joint force. So the mechanical force is going to decrease, which really helps that pressure through the cartilage that we discussed earlier. The other thing that we should mention is that fat cells in themselves are pro-inflammatory. And so through a series of different metabolic functions, that when we have more fat cells, our whole level of inflammation is higher. And so we know that that can cause increased damage to the joint itself. Another one that is a risk factor is when we have weaker muscles. So muscles act to help absorb the shock around the joint and really protect that joint. And we know that if people have a weakness in their muscle, that really leads to osteoarthritis. And so when we are putting abnormal loads through that joint, that really does affect how that cartilage is going through that regeneration, degeneration circle. And so when I say abnormal loads, I don't just mean excessive loads, although that can be. So if you were someone that was doing a very, very physical job for many years over a repeated period of time, or if you were doing an elite sport, like a track athlete or something like that. But also an abnormal load could be a reduced inactivity. So if you were exceptionally sedentary, or if you had a period of illness that you couldn't exercise, or if something else had happened, that can actually lead to some increased osteoarthritis in that joint. And then injury. So if someone has a fall or has trauma through a motor vehicle accident or something along those lines, that sudden trauma can actually start the disease process of osteoarthritis. So we know that certain abnormal loads, injury, and weak muscles all have these sort of consequences and put us at more risk of developing osteoarthritis. So again, osteoarthritis is a result of a combination of risk factors. Some of those, when we manage them, will be better and have benefit for people that have osteoarthritis. So if we can sort of tackle each of those risk factors, we're going to have added benefit. Okay, so I'm sure you wouldn't have signed up for this talk if you didn't have at least some interest that you likely have osteoarthritis or at risk, or know someone or love someone that has osteoarthritis. So you probably want to know what you should do about it. So one thing that we have to say is that once you have osteoarthritis, you will have it for life. There is no cure for osteoarthritis, that it is a disease that you need to learn to manage for the rest of your life. It cannot be taken away. And so any treatment that you have for your osteoarthritis is sort of a time-limited treatment. And the goal is that you should be able to then take that forward for the rest of your life. And so that's really sort of a hallmark that this is a really valuable treatment technique. So this slide is an interesting schematic of a way that we kind of describe how best management that for osteoarthritis, for hip and knee treatment. Now, this is a slide that was developed by a researcher in Denmark. And basically, it takes all of about 50 randomized control trials that support the use of these types of interventions for hip and knee osteoarthritis. So lots of research has been done to sort of boil these down. So if we start looking at sort of that green bar in this pyramid, the first bar there talks about everyone that has knee or hip osteoarthritis should be offered both education, exercise, and some weight loss, weight control. So from an education standpoint, you need to understand what it is, what are the risk factors, and what you can do about it. From an exercise standpoint, we're going to get into that. And we'll talk a little bit about that, as well as in weight control, what we talked about before in terms of controlling the weight. Having a very modest weight loss can help reduce your pain and disability. The orange bar talks about, some people with those three things in the green bar are not going to be able to manage. They still have a lot of pain. They're still limping, and they really need a little bit more help to get through the day. So those are things like having pain medications, having some a gait aid like a crutch or a cane, and some passive treatments that a physiotherapist might offer you. And then, of course, there's people who do need and absolutely get better when they have that joint replaced. But when we look at all of the people with osteoarthritis, and not just if you are one person, but actually if we think you are one person with 4 joints here, right? You're a hip and a knee and a hip and a knee. You only 10% of people ever go on to need a total joint replacement. So really, most joints are going to be managed by those lower 2 tiers, okay? And certainly anyone who needs to go on to surgery, we know that their outcomes will be better when they have a good understanding of what they're dealing with, when they're exercising and their muscles are functioning well, when they have a more ideal weight, and when they're maybe walking a little bit better. So those types of things shouldn't be just passed by. Even if your joint is severely damaged and you do need a replacement, it's still really important to do the little things that we need to do. So again, the treatment for everyone, that we'll just quickly touch on here. So the education, we talked about self-care strategies, and we're going to get into that a little bit more. And we need to be promoting physical activity through that dynamic loading pattern. So understanding that when we load a joint, we will have cartilage cells turn over. And if we completely avoid any load or any amount of compression through that joint, the cells will not have a chance to turn over and have good regeneration, and therefore we can't promote a healthy joint. Exercise, one of the things that we want to focus on is reversing or improving the control of our muscle strength. So we really want to help get that muscle strength, but not just building just strength. We really need to have good movement patterns to protect that joint. And that's a really important thing, is that when we have good movement patterns, the joint will have a nice way that they align, that they will load the cartilage symmetrically and evenly. And certainly we need some weight bearing when we do that. Now, again, some people can't tolerate a large amount of weight bearing. So we might have to do some techniques to decrease the amount of load that you can currently tolerate through that joint or hip or knee. So some people might have to do some walking in the water temporarily before they can tolerate walking, or doing some biking or elliptical before they can tolerate doing more walking for fitness. And that's something where you might need some guidance about how to go about just managing that load, okay? But we do want to encourage some weight bearing through that joint for that dynamic load pattern so that the cartilage can become as healthy as possible. Okay, so when we're talking about an exercise program, we do need these three components, and we're going to talk about the specifics of them in a second. But when we're talking about an exercise program, first we need an aerobic component or cardiovascular. We need some strength or resistance training, and we need some flexibility. And you'll see in the red writing this word neuromuscular, movement control exercises. And that's the part that often gets missed. It's the part that in osteoarthritis has been proven to make the joint both more durable in terms of its cartilage, but also make the muscles around that joint have better control and more precision. And when we do neuromuscular exercises, it transfers not only into the times that you're doing the exercises, but it transfers into every time you get up off the toilet, and every time you get up out of the chair, and when you're walking downstairs to let the dog out, and all of those types of things. So neuromuscular exercises is like the training that we do to become really good movers in our regular world and life. So it's like a golfer that lines up their putt a million times and just does it and repeats it over and over. When we work that way around our hip and joint, our hip and knee, then that's how we will move in life. And again, we have to improve those movement patterns. So in this person, we can certainly see that they have some more poor movement around that joint, which can cause sort of an abnormal load on that joint. So you can see here, this person's having a bigger impact on their medial joint, or the inside of their joint. And when we retrain the muscles, we're aiming to reduce the pressure on that inside and help them balance out the pressures on the joint itself. And that's done through those neuromuscular control exercises. So again, these neuromuscular exercises are the big take-home points, that we need our brain to connect with the muscles that may not be working appropriately because you've had this history of joint disease. And they need to be in positions where you're putting weight through your joint. So they need to be where you're required to have some stability and where you're required to balance a little bit. Really, with these exercises, it is important that you are moving with good quality. It's not necessarily about how many repetitions you're doing, although we do want to build endurance and we do want to do a substantial number of them. but we really want to focus on the precision of the movement. So we want to make sure that they're performed correctly each and every time. So I hope this works. Give you a little video of this guy doing one of those lunges. So this guy is doing a neuromuscular education exercise. So he is focusing on his left leg here. And he's doing, well, now he's going to go to his right leg, sorry, just to keep it fresh. So he's doing an exercise on his right leg to work on the bending of the hip and knee. Sorry, hopefully that wasn't too fast. Just give me a little, was that way too fast? Is everyone okay? Yeah, okay. So that was him. All right. The last thing I'm going to talk about before I give it over to Jeff is just that exercising in pain. So pain is a symptom that can be changed when we move when we are changing our movement pattern. And that typically with osteoarthritis, you will have pain when you move. And it becomes a little confusing because especially in the early stages of osteoarthritis, some people will wonder if they have an injury that is causing the pain, and then should they perhaps take some time to rest. But hopefully today I've given you enough information to say that in osteoarthritis, rest doesn't really work. Rest is something that's going to make the long-term health of that cartilage worse. So we need to figure out a way to exercise that, becomes more acceptable. And so don't worry too much about these numbers, but if we kind of think about pain in a couple different ways, we want you to sort of push through a little bit when we're doing some of these exercises, but we don't want the pain to last later on in that day where it's, interrupting your sleep, or the next day you wake up in excruciating pain. That would not be acceptable. That would be sort of where we would say, okay, we got to back off on some of our exercises. So some of the guidelines I give some of my patients is I'll say, it's okay for it to be a bit sore when you're out doing things. It's okay to be sore during your exercises. It's okay to be sore for a couple of hours after the exercises. But what I don't want is, having to really take a bunch of Tylenol that night for bed, or where you're, still really sore the next day and don't want to get up and do your walk. That wouldn't be appropriate. Okay, so that's sort of the guidelines around exercising with pain. And I'm going to give it over to Jeff now to do some talking about the GLAD program.
Okay. So yeah, this GLAD program was first introduced to me actually from Allison, who found it. Allison's been doing it actually at our clinic for over a year now, I would say. So it was a group in Denmark that came up with an exercise program along with education for people to work through as a small group, and it's been a really great program at the clinic so far. We've had really great outcomes. So basically, everyone that comes into this GLAD program, it stands for Good Life with Osteoarthritis from Denmark. All the patients will be given an education sessions as well as exercise programs, again, in these small groups. It's a 6-week program for the exercise component of it. And then we've set it up now, especially with COVID, our education sessions are done virtually like this. And as Allison mentioned earlier, surgery should only be considered when non-surgical treatment does not show any satisfying results. So in our experience, I would say with our group of people that we've seen over the last year or so, I would say pretty much everyone has had some really has had some great results with this. There's been basically nobody that has had no change whatsoever, that's for sure. So our goals with this exercise and with the education is to reduce pain, reduce the use of medication, improve physical function and physical activity, quality of life, and then have fewer healthcare visits. Yeah. Okay. And then so how this program is set up is, again, you have 2 education sessions. We know in physiotherapy, it's not not just in hip and knee arthritis, but it's in anyone that we ever see coming into the clinic. Understanding what's going on with your particular injury and how to manage it is important. It's important for compliance, and it's important for development. So what we do in these education sessions is we talk about, the risk factors, symptoms, the etiology, management, exercise, daily activities, coping, and self-management. And our exercise program is done twice a week for a 6-week period of time with all the exercises that Ali was mentioning, but a special emphasis on these neuromuscular exercises. So throughout COVID, we've had some people that have done virtual, and we have also still done it in our small groups. In our clinic, we've had 4 to 5 people in the clinic spread out at a time, and then we've also had the virtual. Okay. All right. And this program started up in Canada in 2016. But again, I think it's really growing. I've spoken with some other clinic owners, colleagues of mine, that are starting to implement these programs and are also having really great success all over the country. So this program is available all over the country. It's offered by physiotherapists. It can be also offered by other healthcare professionals like chiropractors. And basically when we do this program, we have 2 points in time where we collect data. So we collect data on that initial evaluation when they first come in. So you have some standardized testing that you do. And then after 3 months post, you are also asked, you're sent some information to fill out to get your outcomes, and then as well at 12 months. So it's very much research along with developing your own program to continue to work on basically for the rest of your life afterwards. So other treatments when we're talking about arthritis, physiotherapy obviously is one of them. That's what we do. Medication, so some topical pain relief. This would be like your Voltaren, would be probably the most common type of thing that you guys probably would have heard about. Any other anti-inflammatory medications. Taping, you'll see some people wearing like K tape, like the stretchy sort of tape, to help improve the proprioception of the joint. So basically helping those muscles, coordinate some movement and activity. We can also see some other type of bracing to increase the stability of your knee, especially in the earlier stages. As your knee arthritis progresses over time, there are some other braces that you can use to increase the stability even further. It actually ends up offloading some of the pressure on your joint. So say if that inside part of your knee was that area where you're having your pain and your restriction, these knee braces actually provide a little bit of pressure on that outside part of the brace to kind of help gap open that inside part of the joint slightly, but more so to provide that stability. So gait aids, you can also be used, what did they have there? So canes and walking sticks. Urban pulling is something that, again, Allison has done, and everyone has had great success with that. There's definitely a technique to urban pulling, though, as I've learned when I went out and first tried it. And then for heat or cold, people ask oftentimes if they have arthritis, do you use heat or cold? It's really based on your preference. Some people like cold, some people like heat. Occasionally, people recommend heat a little bit more before doing activity, but we would actually prefer, some moderate exercise, like some cardiovascular, and that's how we start our program, and how GLAD starts our program is you always start with the cardiovascular component of it to try to get your joints moving. And the other thing that can help to improve some of that stability along through your knee and hip is having supportive footwear, And occasionally we do end up moving to surgery with people with knee and hip arthritis. Now, they used to do scopes. So you may have heard of arthroscopies or scopes where people go and get their their knee cleaned out, or, if they had a meniscus related injury, they'd go and do a scope. There's really not enough evidence that supports that is effective right now. So basically it's not done anymore for osteoarthritis. So in a joint replacement, and a hip and knee joint replacement, basically the surface of your joint is cut off and a prosthesis is put on top. And we know that before you have the surgery, basically the better outcomes are always with the people that move the best and that are the strongest. And there's also been a connection with weight as well. So if you're a smaller individual, and you have the more mobility and you have more strength, generally you have better outcomes afterwards.
Okay, so when we talk about activity, one final little section here. So how active should you be? So this is the new physical activity guidelines. So you might be familiar with the Hal Johnson participation guidelines. Well, they were just updated this past November. And basically they have very similar recommendations with the addition of some information about sleep and sedentary behavior. So when we look at the 24-hour guidelines for people that are 65 and older, one recommendation is that aerobic or that cardiovascular, that getting the heart pumping, it needs to be 150 minutes per week. So that would be, 30 minutes at 5 days a week, or whatever you want to distill it down to. There used to be a clause in there that said that it needed to be in 10-minute bouts or longer, but that's been taken out because they find that people who do 5 minutes here and there are just as healthy as someone who does, an hour a day. So that's been taken out. When we talk about muscle strengthening, we want using those major muscle groups, it needs to be done at least twice a week. So this is sometimes a little bit contentious. People ask me, well, how often should I be going to the gym? We have found that people do not need to be going to the gym necessarily every day, that they can be doing major muscle strengthening twice a week using an overload principle where they get a little bit tired, a little bit sore, and then they have time to recover. And they're actually doing themselves just as good. They're staying just as strong when they have that recovery period. Now, some people like that as part of their routine. So they'll split things up and they'll do upper body 2 days a week and lower body 2 days a week. And so that would be one appropriate way of saying, okay, I'm still getting my major muscle strength twice a week, but I'm not overloading that anymore. And certainly there is a mention here for people that are over 65 need to continue to challenge their balance. So that could be activities like dance, Tai Chi, yoga, hiking on an unstable surface, being outdoors, those types of things. And they do recommend several hours of light physical activity in a standing position. Meaning that, doing more activities upright is better. They do talk about having consistent quality sleep. And certainly that's an addition from the previous guidelines to help with some of the outcomes in terms of sleep. And then this reduction in sedentary behavior. So no more than 3 hours of recreational screen time and breaking up our sitting periods. So you may have heard the term sitting is the new smoking or things like that. And really, when we look at sedentary behavior, it's not necessarily the overall amount of time that you spend sitting, it's the duration of each time that we sit. So if you think of, hunter-gatherers or whatever, if we think of it in sort of a paleontological, study, these people would sit a lot, but they would get up often and tend the fire and sit back down and, weed the basket. So those types of people actually have very good health outcomes because they're never sitting for long periods of time. And so this is why that the sedentary behaviors have been included in the new health and activity guidelines, is that people who sort of putter, move around a lot, don't sit too long, have generally better health outcomes. And then, of course, I have to throw in something about Nordic walking. So again, when we're talking about trying to manage the amount of load that goes through the joint, one option, especially in a pandemic, is to do some Nordic walking. So let me just see if this gal's going to come through here. Whoops. So there is a technique to Nordic walking, but the goal is to really help offload the joint, the hip and the knee. So when you can't tolerate that sort of full force of your weight through the joint, using the poles is one way that we can do that. The other thing is that because you are using your arm muscles, there are smaller muscles in your upper body, which causes your heart rate to go up higher. So you can get a better intensity workout when you're using your upper body as opposed to just using your legs. So that's why sometimes we will encourage people, if they want to have a more intense workout where they can get their rate of perceived exertion or their intensity higher. Because if you remember, sorry, I'm just going to go back to this last slide here. Whoops, go away. So when we talk about aerobic, this aerobic exercise, how much we should be doing, one thing it does say is moderate to vigorous. And so meeting that is sometimes difficult when you have a joint disease, because you think, how can I work out that hard when I can't get my heart rate up? Like, how am I going to move that joint? So that's where things that are less impact are really important. So it could be things like biking, things like swimming, Nordic walking, but we do want to bring the intensity to moderate to vigorous. So what that means is that you're breathing heavy, you're not able to sing a song. You might be able to, you should be able to talk or have a conversation, but you shouldn't be able to, be singing along. You should feel some heat in the muscles and possibly be sweating. Okay, so that's the type of intensity that's really recommended for health outcomes. Okay. All right, go back here. Oh, and then I just had a little bit of hiking because unfortunately, we're not in these settings right now, sadly. I know everyone loves to travel out in Riverbend. So yeah, but walking on an unstable surface and using the poles at times can be helpful, okay? So we'll get rid of that, sorry. Okay.
Okay. And then I was just going to chat briefly about the impact of arthritis in your golf game, which is important to everyone over there at the River Bend, especially this year during COVID times. So basically, if you have hip or knee arthritis that it potentially is progressing and you're maybe haven't been doing anything to improve it, I think one of the most important things that can get impacted is rotation, especially in the hips. What I find with working with golfers that have had hip arthritis. Now, knee arthritis definitely has an impact on more of your walking endurance and how you can set up and be in a squat for sure. But I think with the golf swing being such a rotary move, having hips, which are designed to move a lot into rotation, working well is important. So yeah, hip restrictions can really impact your golf game. If you have some arthritis in hip or knees, it can alter your balance, which can change the way that you swing each time, or you can lose your postures, which can lead to lower consistency, and it just doesn't become as much fun. You're not hitting as far as you used to, because you can't turn as well as you could. You don't have the strength in your legs like you once did. So that's why it's important to get working on these exercises, right? So it's working on, again, these neuromuscular control exercises, range of motion exercises to make sure you move well through your hips and knees, so that you can translate that to your golf course, to the golf course. And then I just wanted to chat briefly here. If you do have restrictions, it doesn't mean that you can't golf. So nobody is going to move perfectly in through their hips or knees. And so if you do happen to have a physical limitation, for example, into hip rotation, generally it's most often with golfers, it's usually our lead side, unless you've had some sort of trauma in the past to impact that trail hip or knee. But usually it's almost on that lead side, always on that lead side, because we're putting a lot more force through that left side when we get to impact, right? Because when we come into our backswing, we're going slowly, or slower. You're translating that weight to your right side if you're a right-handed golfer, and then you're going a lot faster down into that left side. So there's a lot more force on that left side. So you'll see that if we have some golfers that are retired, like Jack Nicklaus, or those types of guys, it's generally always their lead hip that gets replaced eventually, or they've had their lead hip arthritis and it gets replaced, or lead knee. So what can you do if you happen to have a restriction in through your hip? So one of the things that has come back to be more commonplace now, at one point in time, everyone would say, don't lift your lead foot up. So make sure you keep that lead foot on the ground at all times. But they've changed that now. Both the long drive guys end up lifting their foot up so they can create more power. But what you can do if you have a limitation in that hip rotation is you can raise your foot up off the ground, like the guy in this photo here. As long as you get your foot back down on the ground before you start that transition, then all is good. So raising that heel off the ground, which again, I would say within the last 10 years or so with the modern golf swing, people would say, keep that lead foot on the ground all the time. But now it doesn't seem to be as big of an issue as long as you get that foot down on the ground. Okay, and another way where we can try to maximize your hip rotation is add address. So when you're setting up to go to hit a golf ball, so for example, if I had usually in the hip, what you have two different types of rotations. You have an internal rotation and an external rotation. Usually this internal rotation gets restricted the soonest. So your internal rotation for a right-handed golfer would be if I'm turning into my right side is turning internally, which is like your hip turning in this way. So internal rotation is this way. Okay, external rotation is this way. So when I'm going to the right, I'm getting into internal rotation on this side, and then external rotation on this side, and then I'm switching when I get to impact. So the most important one, again, is that lead hip, or that lead side, because we're putting a lot more force through it. So what you could do is like that photo on the bottom, or the image on the bottom right there, where that left foot is turned out slightly. If you have a restriction, you can end up turning that foot out more. If to help compensate for any kind of limitation, right? So you definitely can move around and still swing a golf club around hip or knee restrictions. Definitely making sure we don't have your feet straight on, that there's a little bit of a flare outwards. Okay, and these are just examples of some exercises to do. One is just a balance related exercise where this person's doing some leg swings. Another one's just a hip rotation exercise. And then another thing that we go through with our GLAD program, but also is important with golf, is making sure that your pelvis can move well. So it's not just your hip joint, it's the joints adjacent to that as well. So being able to bend and move through your hips and pelvis.
So I encourage everyone, take my mask off again. Okay, so I encourage everyone that if you have any questions, to please forward them to Kristen now, just while I go through the last couple of slides. But all of the GLAD information is on the GLAD Canada website, and they do an annual report. So if you want to see sort of some of the stuff that's out there, that would be a really good place to go. The Arthritis Society is another good resource. And then the ORSI, so the Osteoarthritis Research Society International, ORSI, they have a lot of the guidelines in the big studies where they've condensed it all down. So I want to just acknowledge that we did share quite a bit of the information with some of these partners today, and the GLAD Canada did help us with some of the slide prep. So thanks so much for your interest. I'm going to stop sharing my screen now. Okay, so Kristen, I'm just looking at the chat box here. So there was one question about heat or cold for osteoarthritis pain. So really, again, that's pretty much patient preference, with the one exception that if you have a sudden injury where you've had a trauma and you're noticing that the joint is red, hot, swollen, that we would say for the first 10 to 14 days you apply cold. But after that time, there's not real good evidence one way or the other. So you can do whichever you would like. Any value to increasing range of motion despite the pain? So flexibility is definitely an important part of any exercise program, and that we do need to maintain range of motion. In the knee, it's exceptionally important that we keep the knee straightening to the full amount. We know when somebody loses the last even 5 degrees of knee extension or straightening, that they really struggle with a normal walking pattern. And so even despite the pain, yes, there is some value into increasing that stretch or that range of motion for sure. And then, like Jeff said, with hip rotation, there is, certain value into helping that along as best we can. But then there comes a point where, okay, that's not necessarily going to change. So is there modifications you can make within your day-to-day life, like flaring out the stance or other things in your day-to-day life that might not be golf related? Okay. So the bracing, do you want to take that one?
And I also think something to keep in mind too with range of motion is that even if you have a really stiff knee or a stiff hip, even a small little gain in that range of motion is going to feel like a fair bit, right? And so any little change that you can get in through that hip or knee range of motion is good. And for some people, it can end up feeling what looks like isn't that much of a change can feel like a significant change. So does wearing a knee brace reduce muscle strength? No, it doesn't. So wearing a knee brace helps to provide you some stability so you can use your muscles more properly. Now, you could potentially reduce or take your knee brace off if you were doing exercises that didn't require additional stability in through your knee. For example, like if you were doing something unloaded, so where you don't have your weight on your joints. So say if you're doing at the gym, doing like a knee extension or a knee curl, something like that, where maybe that requirement of having that additional stability isn't necessarily needed, then you could take it off for that. But for if you did want some additional stability along through that knee, it can help up here for confidence of doing the movement, and can give you your required stability to make you able to do more activity. So and do you need doctor referral for GLAD? No.
So no, you don't need a referral for GLAD. The GLAD program, you do need an assessment by the person offering the program. So right now that's me. And where you need to know that you're safe and appropriate, as well as have the baseline measures that they do for the GLAD program. So we do measures to make sure that you can see that in the 6 weeks you have improved or not. And so we definitely do those measures and make sure that you have the diagnosis of osteoarthritis. Certain insurance companies will pay for GLAD because it is offered through a physiotherapist. This is not like personal training or a gym program. So certain extended health benefits will cover the GLAD program, and certain insurance companies require physician referrals to have coverage. And so you would have to check with your individual extended health benefits for that particular information. That's not my, I wouldn't know. There's a question here about olive oil, and you guys are also so well behaved because it's, I thought it would be cannabis. Come on, what's going on?
CBD, yeah.
I thought it was going to be CBD. So there is no research that I have right now for olive oil or through other supplements. There's a very good, well-informed webinar about the same length, about an hour long, through the Arthritis Society self-management program. So if you go on the Arthritis Society website, they talk about healthy eating, supplements, and it's 2 physicians, and it's quite an informative talk. It was just done in the last year, and so they can give you some more specifics about healthy eating, but that's kind of out of our wheelhouse. The GLAD people do talk about some of the other alternative methods. And again, they sort of defer that the CBD or the cannabis is right now not enough data to know whether or not you're going to have symptomatic relief, because there's so much inconsistency in terms of how much you're absorbing, whether that's through ingesting it, smoking it, rubbing it on your skin. There's lots of different ways. And so they just haven't collected enough data to know how well people are going to do. But there was a recent, like within the last month, the Arthritis Society did a doctor from Ontario who runs cannabis clinic did discuss how they do titrate those medications. So if you're further interested in that, you can definitely go on the Arthritis Society website. Okay. Anything else there, Kristen? Okay.
Nope, that's all that came through.
Okay, well, happy. I mean, I don't know about green beer or Guinness, anything. Come on.
No.
All right. Well, cheers to everyone. Thank you so much for your attention and time. It was a pleasure chatting with you all.
Mm-hmm. Thank you. And thank you to Allison and Jeff for spending time with us tonight. I appreciate this. And I want you all to know that Allison and Jeff and I have a very collaborative, open relationship at the clinic. So if you have any questions or concerns, you can go to them for an assessment, and then we communicate back and forth if there's exercises or something that needs to be observed at our setting at Riverbend. So you're in good hands on both sides. So don't hesitate to call me if you have any questions and want to get in contact with Allison and Jeff in the future.
And Kristen, you have sat in on at least one, maybe 2 classes, I forget.
Mm-hmm.
So she does know sort of and that's really nice for long-term follow-up, because a lot of people say, oh, it's only 6 weeks, and then what do I do for the rest of my life? And so it's designed to be a group program so that we, make the habit and people start to do the GLAD or do some of the exercises. But then, they transfer that to the rest of their gym program. And you don't have to do the whole the GLAD program to get those neuromuscular education exercises. Private physiotherapists that are good should be giving you those for hip and knee osteoarthritis. Even if you didn't want to do 12 treatments at the clinic, you could get those education and neuromuscular education exercises as part of private physiotherapy. That would be a completely normal, a great option. And then Kristen is very knowledgeable in terms of transferring that into a gym program.
Mm-hmm.
Yeah.
Okay.
Awesome.
All right. Oh, we do have one other question. Just let me read it. I'll read it out. Can GLAD be applied for other joint issues? Example, shoulders. So that's the second question we've had about shoulder OA, actually.
Oh, okay. So it's interesting because the GLAD is a program run through the Bone and Joint Canada, and they are actually just starting to make a similar program for shoulder osteoarthritis. And so they're collecting data on that right now. So it's going to be interesting to see in the next 5 years what becomes of that, and if they have more. They're certainly doing quite a bit of research in that area right now. It is true that I would say that in terms of the principles of osteoarthritis, in terms that we do need to exercise, that the exercises may be temporarily more sore or causing a little bit of pain in shoulder osteoarthritis. That's true too. And that we do need to load that joint a little bit is definitely true. And that you need a proper assessment so that you get the exercises that are going to properly load the shoulder joint in osteoarthritis of the shoulder.
Mm-hmm.
So yeah, the principles are very similar. It would just be that there is no right now, there's no sort of package deal. It would be more a one-on-one private physiotherapy situation. Yeah.
Okay. Anybody else? Okay, well, if something comes up, pop it through. And as I said, I can easily send it off to Jeff and Allison. They're happy to help. So thank you all, Riverbenders, for attending tonight on St. Patrick's Day. Enjoy the rest of your evening. And thank you again to Jeff and Allison for taking the time to be with us tonight. I appreciate so much.
Thank you.
Thank you.
All right. Take care. Good night, everyone.
Thank you so much.
Bye. Thank you.
Bye. Thanks.
Bye. Thank you.
Good, Faith. Thanks, Kristen.
Thank you very much. I'm just trying to figure out my stop recording button here. Oh, no,